Picture a clock on the wall, a standard old-school analog clock with the second hand. Tick, tick,
Hmm.
tick. Now, I want you to imagine a patient on the stretcher right in front of you. They are actively seizing, generalized tonic-clonic.
Right.
Every single one of those ticks doesn't feel like a second. It feels like an hour. We all know the neurological mantra, time is brain, right?
We usually apply that to stroke.
But today, we are seeing that in status epilepticus, these prolonged seizures, that phrase isn't just a catchy slogan, it is a terrifyingly literal description of cellular death.
And here's the scary part that we really need to sit with today. The traditional playbook, the algorithm that so many of us have memorized.
Yeah.
The sources we're looking at today suggest it is failing us, and it's failing us badly.
That is the hook for this deep dive. We're looking at data suggesting that patients are often still seizing an entire hour after treatment begins,
Despite receiving what we would technically call gold standard care.
which, neurologically speaking, is a disaster.
An eternity for neurons. You are crossing a threshold where recovery becomes exponentially harder.
So today, we're going to try and rewrite that playbook. We've got a stack of heavy-hitting research here to help us.
We do. We're breaking down the landmark ESET randomized control trial, the latest acute management guidelines,
And a fascinating retrospective study out of Florida on pre-hospital care.
plus some incredibly sharp analysis from the critical care minds at POMCRIT.
And if we put all those puzzle pieces together, what are we looking at?
We're looking at three massive shifts in thinking. First, why we are almost certainly underdosing our first line of defense. Second, the argument for why a drug that has been a staple for decades, phosphonatoin, is effectively dead.
R.I.P. phosphonatoin. We'll get to the obituary in a moment.
Indeed. And third, the rise of a challenger that might just save your patient from being intubated and put in a coma.
Ketamine.
Ketamine.
It feels like ketamine is the answer to everything these days, but in this specific context, the data is fascinating.
It really is.
But before we get there, we have to start in the trenches. Minute 0. The patient is seizing. The first move is almost always a benzodiazepine.
Correct. The sources are unequivocal here. Benzodiazepines are the undisputed frontline therapy. Specifically, the guidelines point to IV lorazepam as the preferred agent.
Okay, but this is where the rubber meets the road, and honestly, where it gets bumpy. We need to get specific on the numbers, because this is where that underdosing trap happens.
Yes, the evidence, specifically from the VA Cooperative RCT, supports 4 milligrams of IV lorazepam.
4, not 1, not 2.
4, and that's a lot. I think for many clinicians, there's a visceral reaction to pushing 4 milligrams of Ativan all at once.
It feels aggressive. You worry about oversedation.
Exactly. And what if you can't get an IV? Because let's be honest, trying to get a line in a thrashing patient, it's a nightmare.
Like trying to thread a needle on a roller coaster?
Then you pivot immediately to intramuscular, or IM, midazolam, and the dose there is 10 milligrams.
Again, a robust dose.
A very robust dose.
So let's unpack this underdosing psychology. You're staring at a patient, you're already worried about their airway, and you think, if I slam them with 4 milligrams of lorazepam, am I going to wipe out their respiratory drive?
Am I the reason they stop breathing? That is the pervasive myth. It's the hurdle we have to get over. The sources address this head on.
And what's the reality?
The reality found in the data is actually the inverse.
The inverse. So using more drug makes them less likely to need a breathing tube.
Precisely. You have to ask yourself, what is the biggest threat to the airway right now?
It's the seizure.
It's the seizure. It's the chaotic event preventing them from coordinating their airway reflexes. It's causing them to vomit, to aspirate, to desaturate. If you underdose, say you give a timid 2 milligrams, the seizure continues.
And the risk to the airway just escalates.
Whereas if you dose adequately that full 4 milligre, you break the seizure.
And you save the airway.
So treating the seizure is treating the airway. Now, the patient will be groggy, that's the postictal state plus the meds, but being groggy isn't an indication for a tube. You have to give them time.
Now, here's where it gets really interesting for me and a bit terrifying. There's a physiological reason why underdosing is such a bad idea. The sources talk about the disappearing receptor.
This is a fascinating mechanism, and it explains exactly why time is brain. So benzodiazepines work by pushing on the brakes of the brain. Those brakes are the GABA receptors.
Okay, standard pharmacology.
During a prolonged seizure, the brain undergoes a physical change. Those GABA receptors, They actually get internalized.
Internalized? What, like they leave the room?
They literally move from the surface of the cell membrane to the inside of the cell. They hide.
That is wild. It's
Yeah.
like you're speeding down a hill, you go to step on the brakes, and the brake pedal just dissolves under your foot.
That is a perfect analogy. And the longer the seizure goes on, the fewer receptors you have available on the surface.
So if you timidly underdose in the first 5 minutes,
You lose your window. By the time you decide, okay, that didn't work, let's give more, the receptors might be gone. The target for the drug no longer exists.
wow. So you basically get one clean shot at using the GABA system.
Correct. You have to make it count.
Okay, so let's play this out. We did everything right. We gave the 4 milligram of levetiracetam immediately, but the patient is still seizing. The brakes failed.
Now we move to the second line. This brings us to the ESET trial. This was a huge deal in the critical care world.
Massive. It was a randomized controlled trial designed to finally settle the debate on second-line medications. Right?
Exactly. For years, everyone had their favorite. Valproate, fosphenytoin, the newer levetiracetam. So they compared all three head-to-head.
A cage match to see which drug was the champion, and the result was...
A tie. A complete statistical tie.
Which feels sort of anticlimactic after all that buildup.
It does initially. The efficacy for stopping the seizure was almost identical across all three groups, roughly 46% to 47%.
Wait, let's pause on that number. 47%. So in a world-class trial, our heavy-hitter second-line drugs failed more than half the time.
It's a humbling statistic, and we'll come back to what that implies. But first, we have to deal with the practical side. If drug A, B, and C all work about the same,
does it matter which one we pick? Rationality would say yes. If effectiveness is equal, you have to look at the tiebreakers.
Exactly. Safety and ease of use. And this is where our palm-crit analysis comes in with a very bold statement.
Which is?
They argue that based on ESET, fosphenytoin is dead.
That is strong language. Fosphenytoin's been the bread and butter of seizure management for a long time.
It has. But working just as well isn't enough when you carry the baggage fosphenytoin does.
Okay, so what's the baggage?
Well, for starters, it carries a known risk of hypotension, dropping blood pressure, and bradycardia.
Especially if you push it too fast, right?
Right. And in an emergency, too fast happens. On top of that, it interacts with everything. The source mentioned dozens of med interactions.
And what about the albumin binding?
That's the detail that drives clinicians crazy. It binds to albumin. So if you have a sick patient with low albumin, you can't trust the standard levels. You need a free level.
And are you getting a free phenytoin level back from the lab at 2 a.m. in time to make a decision?
Never. It's a logistical nightmare with a safety risk attached. Why choose that when you have an alternative?
The alternative being levetiracetam or Keppra.
Which is the polar opposite. It's incredibly safe. It doesn't crash blood pressure. It doesn't have those complex protein binding issues.
Yeah.
You can just give it.
Sort of set it, forget it.
Essentially. But, and this is a big but, the dosing is key. We can't be shy with Keppra either.
What are we talking about dose-wise?
We have to go big. The ESET trial and the latest guidelines use 60 milligrams per kilogram.
60. So for a standard 75 kilogram adult.
That's 4.5 grams.
Yeah.
The max dose, it's a massive dose, and you run it in over 10 minutes. But that's the dose you need.
So the argument is, if you have two drugs that work half the time, but one might crash the patient's heart and is hard to measure, and the other is safe and easy.
The choice is obvious. Rationality dictates we switch to levetiracetam. Fosphenytoin is obsolete.
Okay, so we've swapped out our second-line player, but I want to go back to that scary statistic. Even with the best care, half the patients were still seizing. The palm-crit analysis flagged something really disturbing about the timeline in that trial.
This is the concept of status controversius. In the ESET trial, despite top-tier care, about 40% of patients were still seizing an hour after the study drug was given.
An hour. We're back to that ticking clock.
And neuron death isn't linear. It accelerates. If a patient seizes for an hour, the chances of them returning to baseline drop precipitously.
And the source suggests this isn't because the doctors were slow, but because the protocol itself is slow.
It's a structural failure. Think about the sequence we're taught. Patient arrives. You struggle for an IV. You give the benzo. You wait 5 minutes to see if it works.
It doesn't.
So you order the levetiracetam. The nurse has to pull it, mix it, program the pump. Then it infuses over 10 minutes. Maybe wait another 10 minutes.
You've just burned 30 to 40 minutes just following the instructions.
Exactly. This wait-and-see approach is a luxury we don't have.
So what's the solution? How do we speed this up?
The palm-crit analysis suggests we compress the timeline, We shouldn't wait to see if the benzo works.
You mean give the second drug right away?
Yes. The argument is that they need a maintenance drug regardless of whether the benzo breaks the seizure or not. The benzo wears off.
So as soon as that IV is in, the benzo goes in and the levetiracetam starts running. Parallel processing instead of serial.
Precisely. Trying to get control into that 30-minute mark.
Oh. Okay.
But even if we do that perfectly, we're still left with that failure rate, that 40% of patients who just don't respond.
Which suggests that for a lot of patients, pumping more brakes into the system, more benzos, more Keppra just isn't working.
And that connects back to your car analogy. If the brakes have disappeared, adding more brake fluid doesn't help. You need a different way to stop the car.
You need to cut the gas line.
Precisely. And in the brain, the gas pedal is the NMDA receptor.
This is where it gets really exciting. Enter the new challenger, ketamine.
This is a potential paradigm shift. The physiology here is critical. As the seizure progresses, we know the GABA receptors hide. But at the same time, the NMDA receptors, the excitatory ones, the gas pedals, actually upregulate.
They increase.
They migrate to the surface.
Mm-hmm.
The brain is literally stepping harder on the gas at the exact same moment the brakes are failing.
So the seizure becomes self-sustaining, and ketamine targets that directly.
Yes. Ketamine is an NMDA receptor antagonist. It blocks that excitatory signal. It cuts the gas.
It seems perfect on paper. The mechanism makes total sense. But does it work in the real world?
Well, we have this study from Florida by Zidek and colleagues. It's a retrospective study on pre-hospital patients.
And what did they actually do?
They looked at an EMS system that changed its protocol. Originally, they just gave 2 doses of midazolam. Then they switched to a protocol where if the 2 doses of midazolam failed, they gave ketamine.
What was the dose?
100 milligram IV or IO. A solid dissociative dose.
So they could compare the midazolam-only era to the midazolam plus ketamine era. What happened?
The results were striking. The group that got ketamine had a 94.4% seizure cessation rate.
94%.
Versus 80.1% in the midazolam-only group.
That is a massive difference in medicine. We usually get excited about a 2 or 3% improvement.
It is.
Yeah.
And the researchers did their due diligence. They used propensity matching to make sure they were comparing apples to apples. Even after all that, there was still a 12.4% absolute difference in favor of ketamine.
Okay, but the elephant in the room with ketamine is always safety. It's an anesthetic. If I give a seizing patient 100 milligrams of ketamine, am I buying myself an intubation?
That is arguably the most important finding of the Zidek study. There was no increase in intubation and no increase in cardiac arrest in the ketamine group.
Why? I thought anesthetics suppress breathing. If I gave propofol, they'd stop breathing.
Ketamine is unique. It's a dissociative anesthetic. Unlike propofol or barbiturates, ketamine generally maintains the patient's airway reflexes and respiratory drive. The patient is out, but they are breathing on their own.
So you stop the seizure, but you keep the patient breathing.
Exactly, and that is the holy grail here. The alternative is putting the patient in a coma with propofol and intubating them. Ketamine offers a potential off-ramp before that drastic step.
Sounds almost too good to be true. What's the catch? What are the limitations of this data?
We must be cautious. The Zidek study was retrospective. It looks back at old data charts. It wasn't a randomized controlled trial.
So there could be bias.
Right. And looking at the source, the midazolam dosing wasn't consistent between the 2 time periods either.
Oh, good cat.
During the midazolam-only years, they're using lower doses. In the ketamine years, the protocol had also updated to increase the initial midazolam dose.
So a skeptic could argue maybe it was just because they were finally using enough midazolam.
Not 100% the ketamine. Exactly. But the signal is very strong. And when you combine it with the physiological mechanism, it makes a compelling case.
So where does this leave us? Is ketamine the new standard?
It is currently an emerging second-line agent. It's not the universal standard yet, but the guidelines suggest it's a very reasonable option, especially for refractory seizures.
It's hemodynamically stable, unlike phosphonatoin or propofol.
And it has neuroprotective properties. Plus, practically speaking, it's already on the truck. It's in the ER.
We don't need to buy a new drug. It's likely in the cabinet right behind you.
Exactly.
So let's pull all these sources together. We want to give the listener a clear mental checklist. What is the new playbook?
Step 1. Do not miss the window. Hit hard and fast with benzodiazepines. 4-vilorazepam, 4 milligram.
Or IM midazolam, 10 milligram.
And do not underdose out of fear. The seizure is the threat to the airway, not the drug.
Check. Step 2.
If the seizure continues, forget phosphonatoin. It is obsolete. Go to levetiracetam or Keppra and give a big dose, 60 milligram per kilogram, immediately.
Don't wait.
Don't wait. Get the maintenance on board.
And step 3.
Keep ketamine in your mental holster. If the benzo and the Keppra fail, ketamine is the rising star. It targets that NMDA gas pedal.
It really feels like we are on the cusp of a major change.
I think we are. If you look at the trajectory from the failure of conventional drugs in ESET to the success seen in these ketamine studies, we are moving toward a multimodal approach.
Attacking the seizure from both sides.
With the GABA brake pedal and the NMDA gas pedal.
Which brings us to a provocative thought to leave you with. We know that conventional second-line drugs fail about 40% of the time. Are we approaching a future where we stop doing this sequential wait-and-see game entirely?
That is the question. Imagine a protocol where the moment an IV is established, we give benzodiazepine and ketamine simultaneously.
Shutting down the gas and hitting the brakes at the exact same time.
It would be a radical shift. But given the high stakes of status epilepticus and how hard it is to stop once it gets going, it might be exactly what we need to avoid that death spiral.
Something to mull over. Review your protocols, check your dosages, and stay curious. Thanks for diving in with us.
Stay safe out there.